Hello everyone and welcome to today's live broadcast, How microCT can provide insight into dynamic disease processes, which will be presented by Professor Greetje Vande Velde, Assistant Professor at the KU Leuven. My name is Skeletal, I'm the Market Product Manager with Bruker, and I will be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by Bruker. Bruker enables scientists to make breakthrough discoveries and develop new applications that improve the quality of human life. Bruker's high-performance scientific instruments and high-value analytical and diagnostic solutions enable scientists to explore life and materials at molecular, cellular, and microscopic levels. For more information, please visit the website bruker.com. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting a question if you like at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click on the Send button. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Answer a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located on the top right of the presentation window and follow the process to obtain your credits. Lastly, at the end of the presentation you will receive a poll survey we kindly ask you to complete. Your answers and suggestions will help to improve our webinar program and is greatly appreciated. Now I would like to introduce our presenter, Professor Greetje Vande Velde. Professor Vande Velde is an assistant professor in Imaging and Pathology at the University of Leuven in Belgium. Since completing her Ph.D. at the KU Leuven, she held multiple research positions within and outside the university and has published over 60 journal papers focused around imaging lung diseases and infections. For a complete biography on Dr. Vande Velde, please visit the Biography tab at the top of your screen. Professor Vande Velde, over to you.
Okay, thank you very much, Kiel. And hello everybody, thanks for having me. I can see that you are many to log in. Thanks for that. And I hope I can share some of my experience with preclinical imaging with you, and also some of the enthusiasm that we probably have in common regarding small animal science. So let me start by illustrating a bit what the motivation behind non-invasive imaging is in general. And it is that in general, in many of the preclinical research setups, we want to evaluate a disease model and possibly also therapy, and these are all dynamic processes. So things change and progress and over time. So that's our time course. And in a standard laboratory experiment, this is how it would go with standard equipment. You would have to include different mouse groups to cover different time points to establish and evaluate your pathology in the disease model, to look into the progression. And then in the next step, maybe you want to evaluate a therapy and see how efficient it is to cure your pathology. And this includes different mouse groups or other small animals at different time points, and a lot of work in a classic workup, which means taking out organs, doing histology or other ex vivo analyses. And these are very useful in giving us very detailed information on cellular interactions and so on. But they're also limited to a certain point in time. It excludes any idea on dynamics. And if you work with mice, just like us, you will know that there's always some variation between different animals, and that you often need to include many animals per time point to overcome the variation and to give a certain power to your experiments. And that is where I think the biggest value of non-invasive imaging comes in, and that is that we can do this. To follow up a certain group of mice individually over time at different time points, and in order to be able to do that, we need non-invasive technology. And that is what imaging gives us. Let me maybe first say something about us and what we do. So we're in Leuven, in Belgium, and we are very fortunate to be able to work in an imaging facility which is called Mosaic. It stands for Molecular Small Animal Imaging Center, and it's indeed a mosaic in the sense that different imaging modalities can really provide different pieces of the puzzle. So we operate bioluminescence imaging and other optical imaging modalities such as intravital microscopy. We also operate radionuclide imaging methods such as PET and SPECT. And then we also have imaging modalities that provide more of anatomical and functional context, such as an ultrasound dedicated to small animal imaging, MRI scanners, also a PET MR for simultaneous PET MR, and also a microCT. And the topic of this webinar really revolves a bit around microCT, and to be honest, it's one of my favorite modalities because it's just so versatile. So I'm very eager to tell you a little bit more about our experience with that modality in this webinar. So to give a little bit of a background, so microCT, it stands for microcomputed tomography. For the ones less familiar with it, just a small introduction. So in the microCT scanner, it basically exists out of an X-ray source emitting X-rays and a detector, and then your object or your mouse you want to image will be in the middle. And then the X-rays will actually go through your object. They will be absorbed by different tissues and that have different densities to a different extent along the way, projecting an image on the detector. And if then the X-ray source and the detector, they turn around the object, they will, after the imaging has been done, the computer will compute a three-dimensional image out of all these projection images. So that's where also the name computed tomography comes from. And then micro actually refers to the very small and micron range resolution that a dedicated small animal CT scanner can provide for our research. Now, it's very classically used as a co-registration method to give anatomical context to PET and SPECT images, and it stands for the CT in PET-CT and SPECT-CT, and maybe you're very familiar and you've seen a lot of these type of images, but microCT can do so much more than just providing anatomical context to radionuclide imaging methods. For instance, in our lab, these are the scanners we operate. So microCT, at least for me, it comes in two flavors. So on the one hand, you have dedicated small animal scanners that provide you with a very high resolution for a rather small field of view, and this is just perfect for imaging up to the level of the small bones into a mouse and really provide for detailed analysis of trabecular bone, etc. Also for the lungs and the lung structure at a very high resolution. And then we also operate another scanner, which is very complementary to that, and that actually also operates at a high resolution, slightly less high than the previous one, also at a low dose, but it has a large field of view covering the entire mouth, as you can see in the exemplary images below that. And that's our workhorse for many applications that involve longitudinal imaging, soft tissue imaging, as I will also illustrate in the next moments. And these two scanners are actually very complementary, and it all depends on what you want to do with it. So I hope to give you, in what is about to come, some more insight in what you can do with microCT in a preclinical setting. So to start, and this is really one of my favorite topics, it's lung imaging. And why do we like CT so much for lung imaging? That is that the lung intrinsically gives a lot of contrast. So you can imagine, so there's some soft tissue around it. The lung consists of air and aerated tissue, and then airways and blood vessels, and they have intrinsically very different densities. So with X-ray imaging, this provides a lot of intrinsic contrast. So even without any contrast agent, CT provides you with very nice images of lung and lung pathology. And that's what you see here, for example, for a lung fibrosis model. This is a bleomycin-induced lung fibrosis model. And there you see, for a fibrotic and a healthy control mouse, the difference and the type of images we can get, where you can really see that the darker aerated spaces in the lungs really get filled up with this fibrous tissue after wound healing response upon bleomycin instillation. And then in the next step, based on the contrast differences between aerated and non-aerated lung tissue, We can segment out and binarize the images, so it means that all the white pixels are the aerated content of the lungs, whereas all the black is all the rest. And out of that we can make 3D models representing the aerated spaces in the lung. And this is a measure for how much fibrosis and how sick these animals are. And this we can do longitudinally. So that's the power of microCT. You can really follow up your animals and follow up disease progression week after week after week. And here you can see, for instance, that week after week, the fibrosis really means that the mice have less and less aerated lung space to breathe. And this is a marker for disease. And we can not only visualize this in 2D and in 3 dimensions, but we can also quantify this. And that's what you see here for different groups. And you can also quantify the efficacy of a treatment, which is here illustrated by treatment with imatinib in bleomycin mice, which gives you the quantitative data and the standard deviations which you need to prove whether your curative therapy is working or not. So this is also powerful for other models of lung fibrosis, and also very important here, illustrated by the work of my PhD student Kat, that is that in this model of fibrosis, which is induced by silica inhalation in the lungs and weekly scans with CT, you can see on the scans that the mice get very patchy areas of inflammation and later on fibrosis in the lungs. And in this model, for instance, it goes slowly and it's also very long. So if you want to follow up mice for a long period of time and scan them every week, you can imagine that that radiation dose and cumulated radiation dose is really something that we have to take into account in the design of our imaging methods, and so that it's really safe to scan the animals over and over again with our microCT. And that is what we can do with low-dose microCT, and we can really demonstrate that this is valid to follow up all different kinds of lung disease. And I listed on this slide some examples that we have experience with. And so if this is applicable for your research, don't hesitate to ask me about it. I will now illustrate something more about a lung infection as another example of the power of microCT that I want to illustrate for you. So the lung infection I've been working on, and we work on in the laboratory, is a cryptococcosis infection. It's a fungus that is inhaled in the lungs, and you can already see on the left what healthy lungs look like on CT, and on the right what these infected lungs look like on CT. And I think you can really appreciate that these lungs fill up with the fungus growing in the lungs. But the remarkable thing is that you don't see anything phenotypically on the mice. You don't see any symptoms in these mice. So only microCT at that point in the infection can give us an idea on the extent of infection without having to wait until the mice develop symptoms and eventually succumb to the infection. So that's a very high power of the methodology, and it also refines our experimental setup and reduces animal suffering. So a typical setup is that you would weekly follow up disease progression, and you would really have the dynamics of disease progression for every individual mouse. That's what you see laid out here. So these are weekly scans where you really see the fungus growing and the disease progressing in the lungs. And then we can quantify this, similar as to the fibrosis example. We would binarize, based on a binarization step, the aerated lung tissue from the infected lung tissue. And here you would see on this 2D image that the aerated lung spaces that are in white, that they really decrease over time. And the interesting thing is, when we quantify this for the entire lung, then what you see in the graph is that the air volume in the lungs actually stays the same over time. So these are weekly time points. So up to 6 weeks after infection, in 3-dimensional analysis, you don't see a change of the airspace of the lungs. So if we then quantify other imaging-derived biomarkers, such as the lesion volume, the volume of the infected tissue by itself, then you indeed see what's obvious also from the visual images, that that the volume of the lesions increases week after week after week for the infected mice. And then intriguingly, you also see that the lungs just get bigger, and that's what you see when we quantify the total lung volume. And we can quantify all these things from the same microCT scan that gives us an idea on what's actually happening, that these mice seem to compensate somehow for the infection load in the lungs so that they still have enough air to breathe. And this is actually a fascinating finding that microCT enables us to quantify an image. And then you can also quantify the mean lung density as a biomarker, as a CT imaging-derived biomarker of infection to really follow up progression. And then what I'd like to stress, so this imaging method, so we have the gold standard in the field of lung infection is often to sacrifice your mouse, take out the lungs, isolate them, then homogenize and plate the homogenate for doing and quantifying colony-forming units in the lungs to quantify your fungal burden in the lungs. And here I compared two sets of mice scanned with CT with the golden standard. So in panel B, you see the golden standard for two groups of mice infected with 500 colony-forming units versus 50,000. So a smaller inoculum and a larger inoculum. And because there's a high variation and a high standard deviation on this colony-forming unit counting, with this group of mice, with 5 mice and a bit more in a group, we do not have enough power to resolve a difference, a statistically significant difference between the groups. Whereas microCT in panel A can, which is illustrated for 2 different biomarkers. And with this I want to illustrate that microCT has a higher power and higher sensitivity than the golden standard. So with this is a message that I'd like to give, that it's really important to consider switching to microCT to evaluate infectious load in the lungs. I think it's a very good technology and maybe, well, even better than the golden standard. But I'm willing to discuss that and you may challenge me on that one. So a next thing on our microCT images is yet another biomarker that you can extract from the same scans. And for that I need to say something about the way that we deal with the imaging the motion and the respiratory movement in the lungs. So we actually acquire not only a 3-dimensional scan, but you can refer to it as a 4-dimensional scan, because the 4th dimension would then be the respiratory movement over time. And the way we do this, we do retrospective gating. That also means that we end up with images at the end of expiration and also at the end of inspiration. And if you quantify these sets of images and you subtract them, you can also extract the tidal volume, which is a more functional marker. And this is plotted here for the same cryptococcal infected mice. And you see over time that indeed the tidal volume, so the volume they have and use for breathing, that it remains the same and constant up to later time points in the infection, and also only when the infection is very much progressed, this tidal volume decreases. So this to illustrate yet another piece of information we can get from microCT scans of the lungs. But then there's something peculiar about this infection. So a cryptococcal infection starts with a lung infection and then at some point also moves to the brain, and that's actually part of our research. But then when it comes to imaging the brain infection, then we cannot do this with CT anymore, and now we have to rely on yet another imaging method, which is MRI, to see the brain. And this is one image to illustrate that if we have to find cryptococcal lesions in the brain, that we do this with an MRI scan. So I indicated some of the lesions that you can appreciate following the yellow arrows. And then why is this? And I want to illustrate a bit the differences about CT and MRI. And I think what's important here to take home as a message is that often I get the question, which imaging method is better? Is it CT, is it MRI, or something else? And very often the answer is never that one or the other is better. They're often very complementary. And where one imaging method is good for a certain organ or a certain application, maybe another one is better for something else. And often we need them both if we want to get the full picture of a disease or our disease model, such as in the previous example, we need MRI to look at the brain and CT to look at the lungs. And here I tried listing a little bit of a list, like how CT and MRI are complementary, and you can also see at the images. Because CT is based on density differences, all the areas in the brain and also the lesions, they have a similar density. So a CT image of the brain would show a completely black image. You have no contrast there. Whereas MRI, and this is the strength of MRI, is that it provides excellent soft tissue contrast, as you see in the image. So CT in the brain doesn't give us this anatomical information, but it does give us a fantastic contrast of the skull, whereas MRI, on the other hand, does not give us any information. So also if you would want to image probes in the brain, CT would be much better than MRI. CT has a much better resolution than MRI, but yeah, that is when you need a high resolution. And CT is also easy to use, where MRI then is much more versatile, but this comes at the cost that it may be more complex and it needs a bit of a more expert user level to really get good quality scans out of it, and CT is relatively cheap compared to MRI. But basically, and that's an important thing message that I want to convey, is that they're very often complementary, and different imaging approaches often overcome limitations of individual methods. So that's why we often use CT, MRI, optical methods in a multimodal imaging approach. So another example of how different approaches like CT and MRI can be very complementary, I want to give in the next example. And in the next example, we are going to Barcelona. So for one of my postdocs, I ended up in Barcelona, and there were some colleagues working on a very interesting research. And this research was about Down syndrome. As it was published in 2014, there was a clinical study that a green tea extract would improve the cognitive deficits in Down syndrome. And then these people were working together and looking into people with Down syndrome and kids with Down syndrome, that after publication of this paper, they started taking this green tea extract in the hope that it would improve the cognitive abilities of their kids. And when they were following up these people, they had first the impression that this was also improving the typical facial traits of these kids with Down syndrome. And at first it was an impression, and then it became more and more clear that maybe this treatment with this green tea extract could also improve the typical facial traits in Down syndrome. And that's where my colleague in Barcelona, Dr. Neus Martinez, came into the picture, as she took this and set out to test this hypothesis by investigating the facial traits of these children. So she's looking, so this is her research, to look into whether this green tea extract can really make this improvement by analyzing and doing morphometry on the faces of these kids treated with the green tea extract. And as I was there, and she explained me about her research, which is really about testing and comparing the facial shape of children with Down syndrome and normal children, and then children treated with the green tea extract therapy. And so this is how this is done. And when you hear about trying to get good imaging of the faces of little kids and babies, then everything concerning CT and scanning mice is very easy. So different pictures are taken to a bit like this, to give you a little bit of background on how this imaging is done in kids, to then come up with these type of results, to really look that the younger the kids are, so here you see different treatment groups, that the younger they are, that the treated kids, which are the green dots, they're actually shifting towards, from the yellow dots, which are the kids with Down syndrome, towards the blue dots in the facial morpho space. And this actually means that the younger the kids are, the better the results seem to be. But this is an observational study, and in order to prove this, we need to go to the preclinical side, and that's where I could help a bit, where we would look into whether this green tea extract can really do something on the facial shape. And this makes sense because the brain and the face, so cognition and neural development and the face, are obviously tightly integrated throughout development and growth, etc. And this also illustrates that this often goes together, cognitive deficits with some aberrant facial development in very many other different syndromes apart from Down syndrome. So we set out to investigate this for Down syndrome. So to look into this, maybe you're familiar with this, that Down syndrome is trisomy of the chromosome 21. On this chromosome 21, there's a critical region for Down syndrome, and here you find a gene which is DYRK1A. And this gene DYRK1A is modulated by this green tea extract. So our hypothesis is that the treatment could make sense in the sense that when there's too much of this DYRK1A, when the gene region is triplicated in Down syndrome, that when the green tea extract, maybe this can inhibit this to a more normal level. So in order to test this hypothesis, we set out to do this on mice. And there's a mouse model for Down syndrome, and then to do this, we can scan them with both CT and MRI. And that's what we did here in Leuven with the team. And on mice, you can make really controlled experimental settings. And then we looked together with Neus and the colleagues here at the brain shape and also at the skull shape. And you already see me coming that for looking at brain and at the bones, we need the two different studies, MRI and CT, that work together. So this is a bit what we did. We breed the mice, we have different groups treated with the green tea extract, not treated, mice with Down syndrome and just normal mice, and then we scan them. So just to say something on what we can get with MRI, is when we scan them with MRI, we scan them from when they're really, really small, 3 days after birth, when the mice develop until adulthood at 29 days of age, and we get this typical MR image. And from this one MR image, and that's what our PhD student Sergi is doing, we can do different types of analysis. So, for instance, we can segment the ventricles and quantify the volume, which is important in Down syndrome, because patients with Down syndrome, they have larger ventricles. And we can also look at the size of the whole brain, and then Sergi also analyzes the cerebellum to quantify all these biomarkers that we can extract from an MR scan. So that's for the brain analysis. And then there's even a step further. We can even go to more detailed analysis of the brain, and that is morphometric analysis. And just to give you an idea, so different dots, different landmarks are placed at specific anatomical locations. So this is from a publication, and when we would do this on our scan, and that's what Sergi is doing, he really places the dots on the scans that we have from the Down syndrome mice, and from these dots, different measures can be taken, and they can all be analyzed. And this is really not my expertise, this is the expertise of Neus and Sergi that do very detailed morphometric analysis, but it's amazing with all these landmarks how much information we can get out of the brain. So we can really analyze based on geometric morphometrics, come up with this type of data on shape, on size, on bending, so really on the differences in brain anatomy that are typical in Down syndrome. And then obviously we can also in a very quantitative manner evaluate whether the treatment normalizes this and has a beneficial effect on this or not. So that's the research we're currently conducting with the help of our MR imaging. Now, there's not only MR, so we are also scanning the mice in parallel with our microCT. And because we follow up the mice from really day 3 after development, the mice are in full development. So it's really essential to have a low dose protocol. And we have developed and optimized this with our microCT scanner so that there's definitely no influence of the radiation to these mice, so that we don't induce any dysmorphologies just by scanning. So we can follow this up with our protocol, and even though we have to compromise a bit on image quality so that the protocol is low dose, the images are of a very high quality that allows us to evaluate very many different things. So for instance, we can analyze the effect of the treatment on the mice. So you see here volume rendered images from our scan of the skull, so that we can analyze the face and the effect of the treatment on the face. And with very high detail, we can do morphological visual assessment of any developmental errors. As you can see, different examples here throughout development for normal mice versus Down syndrome mice, and we can really detect and pick up differences due to genotype and also due to the treatment in different doses. We can also look at, with the same morphometric approach, which is the expertise of my colleague Neus, that by putting different landmarks, and the quality of the scan is high enough that we can identify the different anatomical landmarks to put in great detail these and identify these morphometric points on the skull and also on the mandible. And this again allows us to evaluate for the skull and the mandible, what you see here, at different ages. So the mice are scanned at different ages and really see how the differences between genotype and also treatment things evolve. And here, for instance, you see that based on this type of data, we can conclude that the Down syndrome mice are typically smaller. This is very typical, and also that a very high dose treatment can make this even smaller. And then we also have lower dose treatment that's not illustrated here, and then we can really say that this effect is much better and that the treatment can even improve it. So this to illustrate that this technique allows us to assess all these things in the mouse model experimentally. And just to say that this is a type of data that we can extract out of it, so for different time points, really truly longitudinal data on the evolution of these different mouse groups that you here see in the different colors. And then you can really see upon treatment whether the groups shift more towards the wild type phenotype or the Down syndrome phenotype. And then in this way we can analyze in great detail whether the treatment works or not and identify side effects and really optimize the dose of potential treatment. Same also for the mandible, that's illustrated here. And so if you want to see more and also comment on, we published our first details on the experiments on the facial morphology and the treatment here. So you can access this online and also comment on it and give us some feedback on our work. But not only regarding the skull and the face, but because we actually take whole body scans, there's so much more that we can get out of the same microCT scan. And this also gives us more information on the full skeletal development in Down syndrome. And for instance, this is relevant because also people with Down syndrome, they have typically shorter arms and legs, and they also have some problems with mineralization of the bones. And also this we can evaluate from the same scan. So we can see size, we can measure shape, but also important biomarkers such as bone mineral density that are relevant to our animal model. Not only that, but also from the appendicular skeleton, the same size and shape analysis can be done in high resolution with putting the anatomical landmarks. And our microCT data allows us to do that. So we get, as you can see below, we can have detailed quantitative morphometrical analysis that allows us to make conclusions on the efficacy of the treatment, also on the humerus, the scapula, and other bones of the appendicular skeleton. So to wrap up, for me, what makes me such a fan of microCT is that it's a relatively simple technology. It works really well. A scan is super fast, but you can get so much information and biomarkers out of it. So with one single low-dose whole-body microCT scan, we can get information and landmarking and morphometric analysis for the skull and the face. We can also get and monitor very subtle and changes by throughout development and also upon modulation by drugs that interfere with development. We can get all the information about skeletal development for the whole body and all the bones in there, and we can also do a longitudinal shape analysis on the same mice. And because we work with transgenic animals, this is very valuable as you don't have to sacrifice so many animals, but you can just follow the same animals over time. So this is for me the high power and what really helps us, all of us working with mice in our experiments. So I have many people to thank because I'm not doing this on my own, so these are our teams. I'm very grateful to work in such dynamic teams. Thanks everybody. Also thanks for the slides and the images and the help and the result that I was able to present here, and also the funding. There's room for some more. And then I want to say to you that if you are thinking about an imaging approach but you're not sure or comfortable feel free to discuss. We're so happy to help because we're happy that the non-invasive imaging helps us a lot in our research, and we're glad to share with the whole scientific community. So now it's your turn. Feel free to ask. I'm really curious about all the questions that you may have, and I hope I'll be able to answer them. Thank you very much for listening.
Thank you, Professor Vande Velde, for your informative presentation. So if you have any question you would like to ask, please do so now. Just click on the Answer a Question box located on the far left of your screen. We'll answer as many of your questions as possible, and now also give you a moment to participate in our survey while we review the incoming questions. We'll be back in a minute. So hi again, and let's start with the Q&A session. So, Dr. Vande Velde, the first question would be, what was the resolution used to scan the skulls?
We use scans at 50 micron isotropic resolution, and that already gives us very good results that enable us to do all the analyses as I showed here.
All right, thank you. We have a second one coming up. Some people don't seem to have access to such scanners. How would they be able to get access to such imaging equipment?
Well, try to convince your PIs to buy you one, but that's not so obvious. You should take a look around because there are many initiatives and many labs that may have a scanner. So regarding CT, I would recommend to check the dentists in your institution or in your city and bone people, because maybe they have a CT already there, because for that it's much longer a standard equipment, and they're probably happy to share their device with you. Also, at least in Europe, and also this also counts for our facility, they are set up as a sort of open platform. You can always contact us, and also other equipment in, for instance, the Euro Bioimaging initiative, where you can have access to different imaging centers just like ours across Europe. Try to find the machine that you need, the expertise you need for setting up collaborations. So for instance, you can also always contact us. We're also very happy to collaborate if we are able to help for your specific question and help you find, maybe via colleagues, to find imaging equipment. What you can also do is to contact a vendor. For instance, you can contact Bruker and ask them if they know where colleagues in your neighborhood or your country have a machine, and put you in contact with colleagues. And in my experience, imaging people are always happy to share the machine for all the time that they're not using it. So I hope that that is somehow already useful to get you to have access to scanning equipment while you're applying for funding to get your own and have it close by for standard applications. Yeah.
All right. How about this one? We saw that microCT was used for scanning bones, for scanning lungs. Are there any other applications which are possible with microCT?
Of course, and I think we haven't explored them all. So to start with my own experience and the things that we do here at Mosaic is that we also use microCT to monitor metabolic diseases. For instance, to look at body composition, as microCT is also very good in discerning fat from solid organs and soft tissues and the lungs, etc. So fat quantification is a very much used application. You can also use it to do cardiac imaging and cardiac functional imaging. That also works very well, but there you do need to work with a contrast agent. But these are all commercially available, and you can combine that with, you have the whole body scan. So we combine it with a pulmonary scan, so we do that in one go. Other things is that we've been looking at the bladder with microCT by filling the bladder with a contrast agent. We've also been looking at bowel infections. Well, you can always browse and Google, and there are more and more things coming up. And often people just come here to say, like, look, we have a biological question, we have this animal model, what can we do? And then this is my favorite part of the job, then we sit down and brainstorm, and then we see, maybe this way we can do it with microCT, and maybe there the MRI can help, or another approach, and we always come up with a cool idea to make it work.
Okay, we have one more. So the scan is one part of the job, but after that data need to be reconstructed, data need to be analyzed. How difficult is it to process and quantify such data?
Yeah, that's a very, very relevant question. So regarding image acquisition, so there you need to know a bit about the nuts and bolts, because an image, you can have a super good machine, but an image is only as good as the person knowing about the parameters and the person using the machine. But once you have your image acquired, you also want to quantify and do things. And when you look in literature, you will see that people have custom written algorithms and things that you think, okay, I have no easy access to it, I'm not a software engineer, how do I do that? And that is also something that in our approach that we try to keep simple and doable, to find something that is robust and that any biomedical scientist, anybody working with animals can do by themselves. And then we just use the software provided by the manufacturer that is delivered together with the scanner. And that really gives us all the software we need for visualization, but also for processing. And it even allows us to build custom processing algorithms for dummies, if I can say that way, that even if you're not a programmer, you can really build something that works for your mice. So that's really nice. And then also, for instance, to give an example, the way we analyze the lungs, that's something quite easy to do. It's a bit time consuming because we manually delineate the lungs, but once you have that, it's very easy to extract all the biomarkers. The morphometric analysis, that's of course a bit more tedious, and this is really a specialism, and for that I'm really lucky to collaborate with Neus. That's really her expertise. So if you want to do that, you can find a collaborator that's expert in that. But apart from that, there is a lot that you can do just with the software delivered with it and the freely available software like Fiji and ImageJ and so on. So, and what you have to keep in mind is indeed that image acquisition is one thing, but you probably spend a bit more time on the data processing. But even taking all that into account, if you compare it with a standard workup like histology, sacrificing animals, staining, doing microscopy, it's so much easier and faster compared to that. So let data processing not scare you away. That's what I would like you to remember.
Mentioning the faster process, can you give us an idea about how long scans typically take?
It depends on the application. So, for instance, if you have a very quick scan just to have total body anatomy, then you can get away with a scan in 8 seconds, for instance. But for the more higher end CT applications, as the ones I outlined here, it takes a bit longer because you want to scan at a better resolution. So for the Down syndrome mice, I think we're at 3-minute scan, definitely not longer. And for the lung scans, it depends. You can also do a very good lung scan at 3 minutes, but if you want the 4-dimensional lung scan, which means that you have a scan at end of expiration, inspiration, so that you can extract functional information, then you are looking at 10 minutes scan. So it depends a bit.
All right, thanks again, Professor Vande Velde. Before we'd like to go, I would like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today will be addressed by the speaker through the contact information that you provided at the time of registration. If you missed participating in our survey, it will pop up again on your screen at the end of this presentation. Your feedback is important to us, so thanks for participating. I would like to thank again Professor Vande Velde for her time today and her important research. We would also like to thank LabRoots and our sponsor Bruker for underwriting today's educational webcast. This webcast can be viewed on demand through December 2018. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.